Recording started.
Welcome to our November 4th office hours for the End Disparities Learning Exchange. Today's topic is strategic planning for disparities. And we have an exciting discussion that we're hoping to engage you all around with regard to developing strategic planning for our projects on disparities. We do know that there are some issues accessing today's webinar link, and we apologize for that. It's one of the reasons why we record these calls for later access. We're going to have some opening comments and remarks in just a moment, but before that, if you could just enter some information about yourself in the chat room to get us going and so that we can all see who is participating. When you do that, please make sure that the send to is set to everyone so that we can all see each other's responses and all have a sense of who's participating and from where around our big country. I'll start here. Michael Hager, NQC, New York, manager of TA. Great. And while we're typing, we have Emily Chu from the HIV/AIDS Bureau on the line. She is our project officer and our federal partner, and she'd like to provide some words of welcome to you all today.
Hey everybody, I just had to take myself off mute. Welcome to this version of the office hours. We're really excited for this unique opportunity to meet together with each of you and to answer and triage any questions that you might have throughout the End Disparities Learning Exchange. This is really your chance to ask us any questions that may have come up or share your experiences in utilizing the End Disparities Calculator or the intervention tool or even share labs, or to just, if you're new to the exchange, share with us your feedback. What do you think about the exchange? And we'd love to hear it. So I'm really excited to be here with you today, and I'm sorry I'm in transit right now, so I don't have my webcam up, but I will have my webcam up next week for sure. So I'm excited to be with you today, and don't hesitate to ask any questions.
Thank you so much for those words of welcome, Emily. And we know that you're with us smiling along, even though we can't see that giant smile today.
Absolutely.
So for those of you who might be tuning in to this type of program for the first time, let me provide a little bit of background for you. The End Disparities Learning Exchange is a 9-month voluntary initiative that promotes the application of quality improvement interventions to reduce HIV-related health outcome disparities for 4 key populations. And we're doing that while trying to build and sustain a community of learners among RYMY HIV/AIDS program recipients. We have very formal exercises once a month, and then we have plenty of informal opportunities to come together and rub elbows with experts and your peers to discuss issues related to your project in terms of disparities in HIV care. For more information on the End Disparities Exchange, you can go to our website, www.enddisparities.exchange.org. And I just entered that in the chat room for everyone to see. In addition to the main resources and the calendar events that we have on the website, you'll also find an informational video. The End Disparities video is a brief 3-minute visualization of what we're trying to work with in this learning exchange, and we're really excited to promote this and to share this. So please take a look and feel free to share with your colleagues and with your social networks so that we can get as many people excited as possible with the learning exchange. I want to just take a moment to let you know a little bit more about our office hours. As Emily's mentioned, and as I already mentioned, our office hours are an opportunity to informally come together to interact with each other and to really engage in a deeper level discussion around issues related to our projects and ending disparities. They're always going to be on Fridays at 1 p.m. Eastern, but the schedule is variable. So we encourage you to read the newsletters that we send out in addition to checking our Facebook page and also the enddisparities.exchange.org website to identify office hours opportunities that are aligned with your own interests and could be helpful in accomplishing this work at your own home agency. No registration is ever required, and it's open to all. So please feel free to let others in your organization know about this if you think that this is a topic that would be interesting to them. And again, you can see the full list of topics for office hours available on our website. We really are trying to encourage as much open dialogue as possible among you, the Ryan-White HIV/AIDS program community, around these issues. And of course, as Emily Chu had mentioned, there's always an opportunity for a general Q&A outside of today's topic. So anything that comes to mind, or a burning question or issue that you have regarding the learning exchange, you can feel free to ask those too. And today's topic, as I already mentioned, is strategic planning. So at this point, I'd like to turn it over to Lori DiLorenzo, who is one of our NQC coaches. She's going to be walking through some ideas and some questions regarding strategic planning. And with her today is Valletta Reinhardt, who is the quality manager of the Mecklenburg County TGA, which is Charlottesville, North Carolina. And Valletta is also a member of our technical working group for the End Disparities Learning Exchange and has been involved in helping us to generate ideas and to steer this initiative overall from a community planning level. So it's my pleasure to turn this over to Lori and Valletta to walk us through some ideas and discussion around strategic planning today. Lori?
Great. Thanks, Michael. And it's great to see folks on the line. As Michael had indicated, what we're going to be doing for this discussion today, and really want it to be a discussion, we're going to be focusing in on strategic planning. So when we think about strategic planning, I want to throw the question out to you all and really ask that question. When you think about strategic planning in the context of this initiative, what does that mean to you? So what do you guys think?
Writing it in.
You guys can just go ahead and jump in.
We're a small group. Go ahead and shout out your answers.
That's right. I think Sharon, you were going to be talking?
Oh, Sharon?
Yeah, I thought I saw Sharon talking, or was that you, Ellen?
Both of us. What I'm thinking of in this is incorporating it into our integrated HIV/AIDS care and prevention work plan. You know, we have we have work. Yeah, we have the work plan set up for starting in 2017. So we'll add these populations, target populations, you know, to the outcomes. You know. That's what I'm looking for.
So that's really okay. So it's really thinking about how do we integrate that into our work that we're already doing and really focus in on as a subpopulation. That's really helpful.
Right.
Thanks, Sharon. Who else wants to share, you know, what it means to you as you consider this initiative? Or what other things come to mind to you? Go ahead, Ellen. And as folks,
Sharon,
let people know where you're calling from.
We have Cross-Park Collaborative having their next meeting in December, and at that point, you know, we're ending the H4C. That will probably bring this into play, run the disparity sheet that you came out and review it with the group and see where we should focus in New Jersey overall in our cross-part. Since the way we run our cross-part, we kind of are doing a single project for the entire state. So since the one is ending, this will be our next thing. So this is going to be part of our planning of where do we want to go in 2017, what do we want to collect, how we want to work this, and that's my hat as New Jersey's Cross-Park Collaborative, but now as my Part D person that I run the D project, I know I did these numbers already for our D people, and we know where our disparity is, and when I ran it, it's exactly where we anticipated it. It's our 19 to 24-year-olds, or if we want to say the whole 13 to 24-year-olds, because it starts coming into play in the latter part of the teens. We know there are struggling populations, so already I am finishing out what I consider my 2016 quality, and I'm bringing this to my network to say, this is where our disparity is. We are focusing on them already, but this further proves that we need help, and where can we go and what can we do. to plan and help and work on our retention and viral load suppression for our population.
Okay, wonderful. Thanks, Ellen. So we just heard from two areas within New Jersey, with Sharon really talking about how do we integrate this into our work plan and our integrated service plan. So thinking about it from that work plan standpoint, and Ellen's talking about having already identified the population, and then how do we take it to that next step in terms of planning for the interventions as well. So those are two great areas that we're going to be touching upon today. So thanks for the folks from New Jersey. Other folks that are out there, other ideas or thoughts that you have when you're thinking about strategic planning, kind of what's coming to mind for you when you think about what you want to cover or what you want to discover or what are the steps that you're going to take? What are other folks thinking about in respect to this? And if you want to go ahead and put information in the chat room as well, that would be wonderful. So the other question that I have is people are thinking about that. When you take this step back and think about strategic planning as a whole, do you have specific questions that you would like answered over the course of this hour? Things that you want to really explore in today's call, or things that you've just been kind of floating out there as we think about strategic planning. And again, you can share that with us via the phone, or you can go ahead and chat in the chat room. So anybody want to kind of share any questions that you might have? Christine, you were trying to talk, and so you're going to be chatting. Michael, is there any way to look at Christine's to see if she is on mute? Because I'm not seeing her muted.
Let's see. Christine, I have unmuted you. Sorry about that.
No problem. Can you hear me now?
Hello.
Hi. I was just going to say that we in California Department of Public Health, we are also using this data for implementation for integrated plan. We have an integrated plan implementation specialist that's taking that up, and we'll be using our data to inform our some of our statewide activities, but also in terms of clinical quality management, I am looking at our Ryan White Part B data, which is already showing disparities, and I'll be using this with our CQM committee to start prioritizing activities using this data.
Excellent. So I love that fact about really using the information, like you said, in the integrated service plan, but then also bringing it back to your committee and thinking about how you can prioritize and where you're going to be going. I had seen the note from Ellen saying that I was breaking up. Sometimes a headset doesn't always work the best, so please let me know if I'm starting to break up again. Is that any better?
Yes, you are very clear.
Okay, excellent, thanks. Don't always like to have my hand on the headset, but sometimes that happens. Okay, wonderful. Well, Christine, that is, I think, really exciting to think about what you're doing with this for California and really thinking about where we go. And so as we think about starting a project like this and planning around it, around disparities and thinking about the HIV health outcomes, we want to be able to really consider those steps. And, you know, what are the steps that we need to take and where do we need to go with this information? And so the question really is, how do we eat the elephant? Well, we eat it one bite at a time, right? And so we want to go ahead and start talking about how we strategically plan for this initiative as we move forward. So Valletta, let's pass it on over to you and let's talk through some of these elements.
So hello, everyone. I'm Valletta, and as Ryan White funded providers, we are constantly working with our QI projects. Most of the time, we encounter problems, and since we encounter problems or issues, it causes us to ask some essential questions, especially how it relates to data. What do you know, and what do you need in order to identify and understand what the issues are? So my question to the group is, what data resources have you used, what types of database do you use, and what does the data tell you? What do you know, and what issues or problems can you identify and understand through your data? For example, a couple of examples are epi-data. So we know that epi-data is basically going to be demographic information, but it's going to help us identify where incidents are in specific zip codes or certain economic status or certain genders or age. Also, when we look at care data, and client-level data, especially in care where we can use custom reports to, and I know several of you touched on this, we can use custom reports to pinpoint even further populations of who's meeting a measure or who is not meeting a measure. And that helps us to look at those disparities as well. Some of the things I like to do in clinic is sometimes have what I call mini interviews with clients. So I will go in clinic and I will talk to clients to get that one-on-one to identify gaps in services that they feel are missing.
That's really great.
Of course, we conduct focus groups, and that helps us in a larger arena as well. So I was just wondering if anybody else is doing those types of things.
Yeah, this is Sharon. We use, in the New York EMA, we use our client-level data really to drill down to the target populations. And like I said, I've already set up variables for these 4 target populations. Some of them we're already looking at, but, to collect HIV care continuum data for them. And based on that, we'll look at disparities. We'll also enter it into the disparity tool when we get that webinar, and then start working on, first of all, what are the differences? Does anyone have any idea why the differences are? We have a number of providers that work directly with the youth population, transgender, MSM of color is pretty broad as African American and Latino women. So, we'll start by getting a snapshot of what the client level data is as of now, probably as of August 31st, I think, or something like that. And then we'll go from there. We don't have our epi data. The state, we don't get it by, at the EMA or county level. We get some data, but not to the detail that is needed in, for looking at these target populations. And I think the state is just, state of New Jersey, HIV/AIDS division has just started, we're going to start looking at transgender in their surveillance data. So, we'll see how that goes. But right now, we just drill down to we serve like about 6,500 clients. So we're going to drill down to that level.
Good, thank you. Of course, now that we're doing the integrated needs assessment, I think that will help for a more holistic look at care and prevention and everything. I know here in North Carolina we have 2 states. We look at North Carolina and South Carolina as well because we are the TGA for one county in South Carolina, and it really has helped us combat some of those needs and just be a more holistic and collaborative state or area.
Yeah, I agree. In preparing the integrated HIV/AIDS plan, we saw a lot of resources that on the prevention side that we weren't tapping into. We knew about them, but we really weren't collaborating as closely as we should. So that's part of our work plan for 2017, to bring those resources together. And again, focus on you know, these populations, including those that are high risk but not HIV positive.
So then some of the other questions that we would then ask are, where do we begin, and how do you focus your efforts and select your population? And I think we've kind of covered that a little bit as we talked about custom reports and drilling down and looking at various populations. But when we ask the question, where do we begin, we always want to start with the information that we have at hand, which would be first line, the data.
This is Michael. One of the things, Valletta, that you had mentioned that I thought was really, really great was the integration of qualitative data sources, and especially patient experience information as something to support or at least examine a little bit more closely what you're seeing in your quantitative data that you extract from EHRs or careware. Does anyone else do that type of integration of the qualitative and quantitative? And I'm wondering what that experience is like for you.
This is Sharon again. We in the Newark EMA are just starting that, you know, through our QM staff at the, you know, in the Ryan White grantee's office, or recipient's office. They plan to do something similar to a patient satisfaction survey, but really go out to existing groups and develop a questionnaire or talk one-on-one with clients to find out what some of their experiences are, what some of the barriers are, you know, and start looking at it that way. We haven't done it with, you know, delegated the surveys yet, but we'll see how it goes. I mean, we're open to doing whatever, you know, this client level, you know, one-on-one approach appears to be very interesting and something that will really fill in the gaps for our quantitative data.
Totally.
Well, I'm glad you brought that point up, Michael, and it's really great, Sharon, to hear what you guys are doing with patient satisfaction surveys, because the question also comes up is, what are the other data sources that we really can tap into to help us really think about you know, what do we know about these populations, and you know, where can we get additional information, and even taking that step back and thinking about what do we need to know in order to identify and to understand what the issues are. Because I think that the EPI data gives us a place to start. It identifies the trends. Sharon, I thought that it was a really important point that you had made of the EPI data only gives us a certain level of information, and then the question is, where do we look elsewhere for this other, you know, other information, more information? So some of the other groups out there, where are you looking to find and identify additional data that you can bring to the table as you're bringing folks and kind of talking about disparities, one, to identify where we have those disparities, even to start the discussion, but two, kind of what are those resources that we really should explore? So we talked about EPI data, we talked about the client level data, started talking about some qualitative data like patient satisfaction surveys, and Valletta talked about doing some like mini interviews while they're on site there. What other approaches have you guys used to really figure out and understand what's going on? Other strategies people have put into place?
Hi, this is Deanna Kreidler from the state of Oregon, Part B.
Hi.
Great. Hey, Deanna.
There. Actually, I have more challenges to kind of mention, I guess, than, you know, what we're actually doing. What we're actually doing is very similar to what was already discussed. You know, we have the ADAP data. We have our own database. We can pull that data, and we do. We have the careware database, and we pull that client-level data for our Part B case management system. We have the EPI data, which we pull, you know, through surveillance. As a matter of fact, I have our surveillance, my data peer, I guess, in surveillance, who's going to plug in our current data that he just ran for the continuum into the disparities calculator. to see if we get different results because I found the calculator a little challenging, and that's what he does all day. So he's going to play around with it because in Part B in the state of Oregon, we don't have a lot of variation in subpopulations. So we are both very eager to see if the disparity calculator picks something up that we have not picked up in the past in the way that our epi data has been, looked at the population, because of course they're looking at it from more of a overall population statistics, not so much a clinical level, statistical analysis. So anyway, that's upcoming. But one of the challenges I find in even presenting data, which I do to our subrecipients in our Part B service areas, is that, providing the data and saying, okay, these are the folks that are out there in your community, and these are the folks that you are currently serving. What are your outreach efforts? Tell us, what your plan is. And, a lot of times it's challenging because we can't assume that those folks need case management services because we don't provide clinical services. So for Part B, I think we have a little bit of different challenges as a result of that, because the clients that we do have do appear to be getting their medical needs met because we have a great viral suppression rate. We have other performance measures that we can tell that they are linked to care. But the Part Bs, I think we have different challenges, I guess. And so I'm always eager to hear if there's any other Part Bs on the calls or involved in this end+disparities learning exchange, so that I can kind of find out kind of different things that they are doing regarding that.
So Christine, you're calling from the California Department of Public Health. What do you think? Have you had similar challenges as Deanna, or have you found any solutions to some of those challenges? Or
Hi, Deanna. I would definitely want to speak to Deanna more in details. I am having challenges with our system, and I'm new to this position, so I'm still figuring it out. But California is so broad and very unique. I mean, we have rural, urban, people providing different services, so it's been a challenge trying to come to a common ground. So I'm still figuring it out. I'm in the process, and I'm very excited to have these tools now, because I think as a state we've had a problem in a challenge in trying to strategize and prioritize our activities. So this is going to be very helpful. Because of having, we have 42 subrecipients, each providing different services. I will have to kind of get some buy-in from them too, with the approach that we choose for our activities. And data-wise, we use the ARIES system, and I mean, our data is as good as what's being put into ARIES, and we are working to improve that. And we are just now trying to tap into our surveillance data, trying to put our surveillance data into ARIES so that we can have more complete data and have a better picture. And I think that will be helpful. So I apologize to Deanna that I can't help right now, but I'm very open to having ongoing discussions as I figure it out. My committee is meeting now on a regular basis, and I feel like we are making some strides. I just don't have anything right now that's quite helpful.
Well, I think it's great that we're asking this question. And Michael, one of the things that just comes to mind is I'm wondering if maybe we create some affinity spin-off groups and provide an opportunity where we bring Part B programs together to talk about this. We've got, obviously, Oregon represented here. We've got California. Ellen, I know, from New Jersey is representing Part D, but she's also a Part B. She works in the Part B program as well. And I work with Valletta, and we have a couple, at least one other representative from North Carolina, Marianne McLeese, who in North Carolina we run a regional group, and with the health department we just actually put out at our last meeting on October 21st, we talked about using this End Disparities Learning Exchange as our next quality improvement project for the state as a whole for the Part B program. So perhaps this is an opportunity that we create another venue or forum to continue these dialogues. Michael, what do you think? And I know Emily's on the call as well.
I love that idea. And our topic for the month in December is actually working together as a community and a team to end disparities. And I think that we'll have a number of interesting office hours specifically, attacking this in different bite-sized pieces for us next month. But I love the idea of having an affinity group too, because surely having the contact information and making those relationships with your colleagues at other Part Bs, or even other large networks such as, some of the Part As, might have some interesting, advice, and there might be some good back and forth there. So that's a really, really great, thing to keep in mind for our planning group to think about an affinity group for Part Bs and networks to really, kind of chew on this together. What do you think, Emily Chu?
Yeah.
Yeah, I was thinking that Lori was foreshadowing to our December calls, for sure. That's exactly what I thought, Michael. And I thought that maybe for one of these office hours, we had talked about the capability of breakout groups, but the low-tech option would be just pausing, putting a slide up for Part A's, Part B's, Part C's, and D's. Of course, then you'd have to be comfortable sharing your information across the whole group. But I think that that's something that we could definitely talk about and really try to facilitate for you guys, because I definitely think that there are nuances and needs associated with each of the parts, especially for those of you that are multiply funded. We're seeing from HAB that a lot of our participants are multiply funded and they have special needs it would be helpful for an affinity group to kind of bounce those ideas off. So yeah, I think the idea is great. We'll just have to, it'll be our challenge as the faculty to kind of hash out the logistics.
Totally.
Sounds good. Well, why don't we keep, talking about this? We've spent a little bit of time talking about, what do we know and what are our data resources, and how do we begin really identifying where we're going to start with this. And so the next question that Valletta started talking about is, where do we begin to hone in on a specific population, and how do we focus those efforts and select your populations? And actually, it goes on. You guys have already started talking about the disparities calculator. Michael, do you want to go to the next slide so that we can see? It has the visual from, this isn't live, but it is a screenshot from the End Disparities website that provides the overview of the Health Disparities Calculator. And this is a great tool that we're hoping is going to help you determine where the potential disparities lie. And from the screen, you can see that there's a lot of supporting materials that go along with this and helps you walk through the calculator itself. Michael, remind me, when is the webinar that's going to walk people through this?
Yes, we're going to be talking about this on November 17th at 1 p.m. Eastern.
Okay, so that is less than 2 weeks away. And I know that I'm breaking up again, so hopefully this one will sound a little better. So thanks. So November 17th, perhaps we can just type that into the chat so everybody has that as well. So Disparities Calculator is one tool that once you have your data, you can identify where the disparities lie, and it can then help you as a group to really hone in on those subpopulations. Besides the disparities calculators, are there other tools and resources that you know of or that you have in terms of steps that you want to take in order to focus your efforts and select that population? Other ideas that you might have? We have a lot of information that's out there on the Disparities website. Michael, do you want to show the next one? One of the other items that has been created is called the NQC Share Lab. And what it is once you've identified your subpopulation, the Share Lab actually provides you information around a range of interventions that have been implemented by agencies. And what this Share Lab is doing is you can see you have the larger, I guess, root, I would call it, or the root of the tree, the root ball that right now what you're seeing is listed as retention. And you see the number 784. Well, what that means is that there are 784 different strategies that are captured around retention. And then it's the question of, wow, that's a whole bunch of strategies, right? Well, where do we go from there? So from there, you follow the roots out to the different, it could be a root or it could be branches, if, you know, using a tree analogy here, where they're broken into different categories or classifications to give you some insight around perhaps where you'd like to explore. So you can see we have some that focus in on capacity building, and I think there are, it's hard for me to see, but I think there's 63 different interventions there. There's case management, some evaluations, something about health systems. So what it does is it takes you into different categories, and it gets finer and finer to specific interventions. And as you click on each of those circles, it will get you ultimately down to the specific interventions and the specific agencies that implemented it. So it gives you a great starting place, because coming back to that slide we had at the beginning here of how do we eat the elephant? Well, we got to do it one bite at a time. So we have to first look at the data to see, you know, what's it telling us and where do we focus. And then from there, what are some of the interventions that we could potentially do? And this is a great place where you could go ahead and start. Michael, can you pass on to the next slide?
You bet.
So what we also have is, if you move from Share Lab, which gives you lots of different information about general strategies and interventions that have been put into place, but then there may be the question about, well, what about the specific populations we're talking about? Because we're really looking at 4 populations with this particular learning exchange. And so on the website, and again, this is another screenshot here, and we encourage you to go and play around if you haven't already done it, is it gives you information about the interventions by population. And there is also a spreadsheet that captures, and this actually may feed into that, but there's a spreadsheet that captures the different interventions by population and by agency. So you can find out who's implementing it, and really it's designed to facilitate that peer-to-peer interaction. Because if you guys have ever heard Clement Steinbach talk, and he talks about, you know, where are the solutions found? Well, the solutions are found right in our own backyard because we have the expertise, and it's a matter of hooking up with those particular agencies and individuals. And just like Deanna and Christine, you're talking about, you know, with Part B, and, you know, can we talk about within our respective programs, the same thing around these interventions by population of where do we go and, what, you know, where can we start? So this gives you some tools on specifically opportunities and options to go ahead and explore. So questions about those elements, and really kind of thinking about where do we begin and how do we focus our efforts or select the population? Any questions about that? So I know New Jersey has already selected their population. Of the folks on the line, have other groups gone ahead and already identified which group you're working with? And if so, do you want to share who you're going to focus on? You can put it in the chat room as well.
Well, in the Charlotte TGA, we will probably focus on the youth group because we do have a large number of youth who unfortunately are homeless, and so that causes a lot of medical non-adherence. So we're going to try to focus on the youth and see how we can get them back into care and virally suppressed, and also help work on their homelessness situations in the process.
Excellent. So we know New Jersey and Charlotte, Mecklenburg are going to be looking at the youth population. Is anybody picking any different populations that you think you'll be working on? And it may be early on in your process right now. Okay. So those are some of the things to think about. So California hasn't yet identified it. You're going to go ahead and meet and discuss the data. So that's great, and that's the place to really start, is thinking about where are we at, so that you can make the most of your time. One of the things that I would encourage the different groups to do or to not do is pick one population. Don't pick multiple populations at this point. Really focus your efforts. You can always go to another population after you've gained experience, but you want a success. You want to see how this plays out so you can continue it on. Okay, so let's go to the next slide then. We've talked about what do we know, how do we use our data, where do we begin, how do we focus our efforts on the select population, and the next one is who do we engage? So who needs to be at this table when you're starting to plan or get involved in the planning itself? Sharon, you talked about bringing prevention to the table, and you know, when you were working through like the integrative service plan, realizing that there are so many different resources that are out there. When you guys think about how we strategically plan for this learning exchange, who do you need to bring to the table? What are you guys thinking about? Where are you starting and where are you going?
Okay, I think for us, when we saw the resources, what we found was that it was just a lack of information, because many of our Part A agencies also get counseling and testing funding and prevention funding. And so we have regional collaboratives that do early intervention and retention activities. So it's just a matter of highlighting those resources and identifying how those prevention resources can feed into, you know, the care and treatment continuum. You know, we're looking at two, you know, for our, first of all, for our Part A grant and for our integrated HIV/AIDS plan, you know, we're looking at both the HIV care continuum and that HIV prevention continuum that was presented at the the National Ryan White Conference. So understanding that piece, you know, is bringing the people together to start talking about how the resources fit. So, you know, and you know, in terms of the populations, you know, we didn't sort of, when we looked at for our Part A, for, you know, we have to do certain ones, and our target groups were youth, you know, already for our EHOP plan, youth, MSM of color. We also looked at women of color, you know, and we found that Hispanic, Latina women had better outcomes than African Americans, so we're going to have to drill down to that population. But, you know, we'll bring the resources in, identify what everyone is doing, information sharing, and how we can, what strategies we can use, what strategies have they used already to reach the target populations, especially youth, and then how we can improve outcomes.
Well, and I love that fact about talking about strategies that that they've used that have been successful as well, kind of what's already in play. And actually, I'd throw out a plug. Remember that Share Lab that I showed the screen there? That is actually designed to be a process in which we are learning from one another. So as you guys are working in this and as you implement your interventions, what we want you to do is post your strategies in the project Share Lab so that we can continue to expand that. So we may start with, say 500 interventions at the beginning of this. Hopefully by the end of this 9 months, we'll end up with 1,000 plus so that everybody is contributing. And that's what this is designed to be, is a learning exchange. So really am excited to hear about where you're going with that and what New Jersey is going to be doing and who we're going to be bringing to the table in order to plan this, this session. Kirsten or Lauren, we haven't heard yet from you. Can you share a little bit about maybe what you're thinking about of who could potentially be engaged in this learning exchange and who you think needs to be at the table or involved in the planning? And you may be on mute. Oh, well, they're getting themselves off the mute. Anybody else want to share some ideas of who should be brought to the table? Who knows or represents this population?
Hi, this is Deanna Kreidler again. In the state of Oregon, our plan is to not only look at this from the Part B in our perspective, as well as, you know, the HIV medical case management, ADAP program, but also with our Part A, we have a statewide QIC, and given the 5-year new integrated plan that's being rolled out, we are going to be looking at ways to use this statewide QIC not only for the plan activities and objectives, but my goal, too, is to also do something with the end+disparities learning exchange through that QIC collaborative.
Excellent. So really being able to bring it back into, you know, existing meetings and committees and forums so that you can continue to explore the issue. So I love that idea. Thanks, Deanna. Anybody else?
Hey, Lori, it's Emily from HAB. I heard an interesting story about an individual at a Part C funded organization that really took the premise behind this learning exchange to their consumer advisory board and said, you know, put your finger on the pulse of the population that we're serving. What's your feedback about this, just to really get the wheels rolling and get people thinking in terms of the learning exchange? And it actually uncovered some interesting populations that were being served but not actually really being captured, particularly young women living with HIV, young women of color living with HIV. So it was actually a really powerful experience. So in terms of the recipient side, I think that being creative about stepping outside of your own position and asking the people that you're serving what their perspective is a good example of something to move forward with.
I love that idea. The consumers can really provide some insight with this, and I love that comment about step out of your comfort zone, step out of your, you know, traditional box that we put ourselves in, and really think about what are the other groups that can be brought to the table that you may not historically be working with. Think about the champions of these specific populations. Think about, you know, oftentimes we think about our providers, our frontline staff. Think about the program leaders and what Deanna was also talking about of looking at the larger systems of care like Part B and Part A. And then, of course, any other key informants that might be out there as well that we haven't necessarily thought about. Sharon, I think, had mentioned the prevention group as well. So really thinking about, as you're planning for this learning exchange, who are our regular folks that we bring to the table, but who are the ones that can help push the envelope and perhaps we've not invited to other initiatives in the past. So thanks, Emily, for that. Let's go ahead and keep talking. Michael, can you move us on to the next slide? And I think, Valletta, this one comes back to you.
So the next question is, what do you do to plan? And some of the things, I think we have a few examples, but what are the first steps that people usually take when they want to start to work on a QI project? Well, some of the first things would be to identify barriers, issues, problems, and as Lori said, to identify those who should be at the table, who care, and what they care about. Michael, if you could go to the next slide, we'll talk a little bit about methods, techniques, and interventions. So we have an AIM statement from Missouri. And with the AIM statement, the thing that you were trying to figure out is, what are we trying to accomplish? What I like about the AIM statement is that it has an overall quality statement, and it defines what you're going to be measuring, the project that you're going to be measuring. Sometimes it'll have baseline data on the AIM statement, and it targets your team set to achieve the goals for that measure. So what we've learned from this AIM statement is that they want to underline, increase the, improve the care for the residents living with HIV. And how are they going to do that? They're going to do that by looking at viral suppression and retention for their population. How much of an increase, or how much are they going to, what's their goal? Their goal is to increase it by 5% by December. And even though it says December 2014, we'll pretend like it's December 2016. So what is the goal? The goal is to increase it by December 2014. And is the goal measurable? Yes, they're increasing it by 5%. So this is like all in one little snapshot. You can see that what their goal is, what they're trying to accomplish, why is it important, what's their specific target or what they're measuring, and when they're going to do it by. I don't know if many people use AIM statements. I've used them every now and again, and I think that it's good when you want to show people a total snapshot all at once.
It seems that AIM statements with that type of snapshot is really important if you're going to be interacting with or interfacing with stakeholders who aren't at the table every day. So, you know, thinking back to some of those consumer groups that you may not see every day, like a CAB or a board committee, other stakeholders, perhaps your project officers or other groups that are interested in how you do this work. You know, it's really great because then they have a sense of, you know, what you're planning to do and how you're planning to do it all in one shot, as you said, Valletta. That's great.
And so we have another, we have a root cause analysis. And with the root cause analysis, it tells us why a problem happens repeatedly. If you don't identify the root cause, then of course the problem's going to keep reoccurring. Most of the time when you find the fundamental level of what the root cause is, it'll help you resolve some other issues. With root cause analysis, brainstorming for major categories, as we see on here, there's environment, procedures, people, and equipment. So our goal is, or our problem is the low rate of pap smears. What's causing the low rate of pap smears? So once you start the brainstorming process with the major categories, you want to put those as headings. You can also use little branches to have sub-causes, write those write those right across there and keep asking, why does this keep happening? And as you keep asking and people keep answering, you want to write all that down. Once you keep asking why, and once you look at what you've got going on, you can really dive deeper into levels that will help you generate some answers. Now, the reason I like this particular root cause analysis fishbone diagram is because I know several areas here have used these for exactly the same thing. Why is the rate of Pap smears so low? What they found out, one clinic found out that it was all about procedure. Once they started looking at there was not enough time, there was not, they had not explained what they were going to do in the visit, and so people were not prepared to stay or did not want to have their Pap smear done because they weren't informed prior to the visit. That was an issue. Another clinic found that it was equipment. So the client is in the exam room, but now the nurse is running around trying to find the setup to do the Pap smear, and then people are saying, well, I don't know if I want to stay, it's taking too long, and then you only have so many minutes for the visit, and it keeps running longer and longer and longer. So as an intervention, the clinic in Gaston, they decided to put the setups for PAPs in the room, and so when the client is there, if you ask, would you like to get your PAP done today, there's no running around looking for the equipment. You can proceed right ahead. The same thing with the other clinic. In their procedures, they changed and they decided to have 2 women's visit clinic days a month. And so you already know they've told you that this is what's going to occur when you come for the visit, and there's no surprises. Let's see. There are other methods that you could use, QI project memos, PDSA cycles. I like to look at one particular book called the Quality Toolbox, and they have about 100 different techniques that you can use to get started.
So I see the time is now 1:59. We did get started a little bit late, so I think, I'm willing to go maybe 2 minutes or so later. But I don't know, Lori and Valletta, are we ready to move on to our last question?
Yes, I think that would be great. So one thing, and the other thing to keep in mind as we think strategically for this initiative or any other project is you need to think about the sustainability. How do we proactively plan for this initiative? And as we do that, we really need to consider how we're going to sustain the efforts beyond the life of this project. In this case, beyond the 9 months of this official learning exchange. And as you think about building your plan, you need to build sustainability into that plan. So think about steps that you need to take in order to sustain the games. And I know we don't have time to delve into these, so I'll throw out a couple of different ideas before we open it up just for some general questions about the learning exchange itself. But think about how do you routinely share your findings and you report to the respective stakeholders, making sure you're providing updates at various staff meetings. You want to make sure that you have a team that's working on this so that you can track and maintain those gains over time, and think about how you're going to evaluate it as well. How do you assess whether or not you were successful with this? Build in opportunities to do storyboards or presentations at different conferences and meetings, and make sure that you're building the infrastructure into your program. So if you're creating specific interventions that are going to require policies and procedures, that's a way to institutionalize the intervention itself, and you want to make sure that you consider staff training. So a couple of things just to seed some ideas. Think about as you're planning for this, you start from the beginning. What do you know? What is the data telling us? Help us identify what the target population is. Begin to think about what are the interventions we need to put into place, understand what the problems are, plan, use the tools that are out there, and then think about how we sustain the gains. And so that's really taken us from beginning all the way to the end to sustain those efforts over time. So proactively plan for this learning exchange. Michael, turn it back over to you to bring us on home.
All right. So I just wanted to take a moment to check in. And I think that with limited time, we really want to ask the second question. What feedback do you have on our office hours? How are we doing, and what works well and what doesn't work well? Should we have more or less structure? I'm just really interested in hearing your thoughts now about the type of informal discussion environment that we are creating for you, and if we're doing a good job with that. Okay, and because I know that some folks are a little bit shy, I've opened the poll here for our official evaluation. This is another way where you can let us know how we're doing. We're really interested in your feedback. We want to make these, engagements as useful as possible for you. So any feedback you have for us at all, in terms of how we can make this, more useful for you and meatier for you, please let us know, and we'll be happy to work on that for you. While folks are filling out the evaluation, if you have any other ideas for the learning exchange or how we're doing with the learning exchange, you can feel free to share those as well. I see a lot of positive comments. Thank you for all of those. So thank you very much for your time today in joining us. We know that time is precious and that you have a lot going on. It's the beginning of grant writing season, and a lot of folks are working on those integrated plans. So thank you so much for your time today and for joining us at this office hours presentation. And we're looking forward to seeing you again next time. Our next event is going to be our webinar on November 17th, where we're talking about using data to set baseline, setting baseline data for use in our disparities project. There we go. And we'll also be introducing our consumer involvement aspects called Partners in Care on that webinar. On the following day, November 18th, we're going to have a special session on helping consumers understand baseline data, because if we want to involve consumers meaningfully in this effort, we have to have some way of communicating nuances and sensitive information around data to them and with them. So that's our next office hours on Friday, November 18th at 1 p.m. Eastern. Thanks again for joining us today, and thanks for all you do, and we'll see you again next time. Have a great day.
Thanks, Michael. Thanks, everybody.
Thank you, Lori and Valletta, for your presentation today. It was really wonderful.
Thank you, Michael.
Thanks, Valletta.
Thanks. Bye.
Bye.
Bye-bye.